Meeting of BudgetSub5 will come to order. The hearing today will focus primarily on inmate medical care and alternative housing for CDCR inmates. So the first discussion item is an update from the federal receiver, Clark Kelso, on the status of the receivership and the transition of healthcare responsibility back to CDCR. Welcome to the committee, Mr. Receiver. Yeah, we're looking forward to your update.
Thank you, Madam Chair. Clark Kelso, Federal Receiver in charge of medical care. I have with me Joyce Hayhoe, my legislative representative, who can answer any questions that I can't answer. And of course, Diana Tosh, the Undersecretary for Health from CDCR. In terms of an update on the receivership itself, I think there are three things, maybe four things worth mentioning. The first is we are continuing to make progress in the implementation of a digital medical health record. This was a project that began several years ago now. It was the next logical step for us to take in trying to make sure that health records within the prison system would be accurate, would be updated on a timely basis, and would be available to all clinicians throughout the system as necessary. We have had an implementation at 3 pilot institutions. After the pilot implementation, we are spending a little more time than we had planned to correct some deficiencies, particularly in the way in which the pharmacy system operates. We, at this point, believe that we have solutions to the problems that have been identified, and will be starting up the statewide rollout in several months. We will be rolling it out probably at 2 prisons at a time initially. There is a very large workload in transitioning into the medical record system. There are a huge number of prescriptions that have to be entered into the system. And this is not something that can be done just automatically, so we can't just have an easy technology bridge into the new system. We have to have appropriate clinicians essentially validating all of the prescriptions. And that workload is so substantial, it does impact how many prisons we can roll out at a time. We know from the 3 pilots that apart from the pharmacy set of issues, the system that we've procured is working properly. Doctors are using it. At Folsom, we know that it's improving the way in which they schedule encounters with patients. For example, they used to have sort of, okay, I've got to have a chronic care appointment, and you do that chronic care appointment, and then 2 weeks later you come back in for a different appointment for a different set of issues. Folsom has figured out with the new system how to put those all into one appointment so that you can be quite a bit more efficient in treating the needs of patients. We're going to be looking for those type of improvements in efficiency at all prisons as the system rolls itself out. So that's one thing that has happened since we last were here that is a positive development. Second thing, we have begun implementation in January of a complete care model for how we are managing the care, particularly of our chronically ill patients and our most seriously ill patients. This is an initiative that's designed to make sure that those patients don't fall through any cracks in our existing care system. Essentially, I'm oversimplifying greatly, but essentially at each prison, we're going to be having a supervising nurse who is going to be responsible for managing a panel of patients. And as I understand it, what happens in this sort of a system is that person follows up with anyone necessary across the continuum of care to make sure that a patient's needs are being appropriately met. It is similar to systems of care that are employed in the private sector to make sure that you don't lose patients, essentially, inadvertently. That was about a year in planning, and the implementation has begun in January of this year. And I think it will result in a measurable and visible improvement in continuity of care and quality of care. Third thing, we've made continuing progress in our quality improvement and quality management function. We have, over the course of the last year, reinstituted with additional staffing at the regional level some quality resources. We've been focusing at all institutions on improving their adherence to requirements that they meet regularly to consider quality issues and to analyze quality issues. And at the headquarters level, we really have, in a very recent report that we will make available to the committee, I think demonstrated that across the board, we have learned how to make improvements more rapidly than, say, 5 years ago. In short, we've learned how to cycle through improvement initiatives more quickly and more efficiently. And I think that speaks well to one of the court's issues regarding sustainability into the future. Judge Henderson is very interested in whether we're at the point that we're able to diagnose our own issues, our own problems, and then have a quality improvement process that resolves and fixes those problems, instead of being in a position where we're waiting for something bad to happen as the way we identify problems. And in particular, something bad happens and the prison law office or the OIG has to identify problems that we were unaware of. And I do believe the quality management report indicates pretty clearly that we're beginning to be at this point now where we know where our own shortcomings are and we're able at a both system and institution level to address those. Fourth point relates to process of delegation. The subcommittee report does a good job of explaining what the process is at this point. We have delegated Folsom. That was done last July, I believe it was. A second delegation of CTF I executed a week or so ago, 2 weeks ago maybe. The delay between those two related to my need to work with the OIG's reports and then reports that I received from 3 court experts who had been appointed in this case some 10 years ago, medical experts. The medical experts, according to the court order, I'm required to consult with before I do a delegation. Essentially, there was a disagreement about the quality of care at CTF, the extent of any problems there. And I needed to spend a fair amount of time both digging in at a very detailed level to what were the basis for the disagreements. So I was looking at individual patient charts and trying to reconcile differing viewpoints. And a second big issue that I had to spend a fair amount of time on was trying to figure out what's the standard for finding that an institution has reached a constitutional level of care. It's an issue that this committee has asked me about repeatedly over the years. I am now at the point where I at least think I can articulate what that standard is, and I think I can see whether an institution has crossed that threshold. That all took a lot of time. I can assure the committee that further reviews are not going to be taking that much time. We have already scheduled meetings with the parties on a monthly basis going forward. I need to essentially catch up with the Office of Inspector General. They are on a good schedule. I believe they will finish their reviews of all of the institutions by the end of this calendar year, and then they'll begin a second round of reviews. And what I need to do is catch up in my evaluations so that they're not so far ahead of me, and we will be doing that.
Okay, thank you very much. Does CDCR have any comments?
So I agree with the receiver as thus far, with the complete care model rolling out, that is coupled with the rollout of the electronic health record, we're on a path to delivering good quality care and being able to assess the care that's being delivered and make adjustments in a timely manner. And so the report that Mr. Kelso was referring to outlines some of the initiatives where we've actually had that rapid cycle change. And the quality management group at headquarters has created numerous learning collaboratives and also some registries and other tools to assist the institutions in achieving these goals in the interim in between having the electronic health record and we're waiting for its complete rollout.
Okay, does the LAO have any comments? No? No comments from the LAO? And how about the Department of Finance? Okay, no comments from the Department of Finance. Well, I do have a couple of questions for you. Let me say, I think that the automated records rollout is very positive. I've seen it work in my own doctor's offices, and I'm assuming that once it's rolled out, it should lead to better health care and lowered expenditures. I also am pleased that the rate of preventable deaths is down significantly in the department. It's down by about 54%. Also to note that our medical costs have almost tripled since the receivership was put in place, and it has been 8 years since this receiver was in place, 10 years since the courts said we have to get serious about change. And of course, it was 2002 when we had the stipulated settlement in the Plata case. So, I do think it is time for us to move ahead with all deliberate speed. So if you could just tell me succinctly, what procedures are now in place throughout the system so that we know or can be assured that adequate care continues when the receivership ends? We've already had one facility that was returned to CDCR's authority, remanding back to the receiver, and I think that's an ongoing concern. If either of you could address that.
Yes, thank you, Madam Chair. I think several changes that have happened over the past years make it very likely that the department will be able to maintain the improvements, and the legislature will be able to evaluate for itself whether those improvements have been maintained. We have developed, as I think the committee knows, a robust dashboard reporting system that permits us at a statewide level, at an institutional level, from a disease perspective all the way down to individual doctor level. It permits us to evaluate on an objective basis the degree of compliance with our own policies for timely access to care, and it allows us to measure in the same way, basically, that the private sector healthcare measures outcomes. So we actually know for our major chronic conditions what the population outcomes are of our entire patient population, and we are comparing our outcomes with the private sector and make improvements when necessary. All of this is publicly available information. I assume and believe that it will remain publicly available after the receivership ends. That provides a basis really for everybody to see whether quality of care is improving, staying about the same, or going down. There's, in other words, a lot of data that will tell you whether things are going poorly. The second major change, I think, is within the department organizationally, is the fact that there is now a separate undersecretary focused on healthcare. And in my experience within the department, and the committee knows undoubtedly better than I do, that type of organizational visibility within CDCR is very important in terms of getting cooperation and collaboration between healthcare and custody staff, and simply in the discussion of what resources you're going to put to different programs. And we've developed a very good relationship with top executives and with the undersecretary. That gives me a fair amount of confidence that the improvements that we have made will stick.
Okay, and this question is actually for both of you. We've all been concerned about the ongoing tension between custody staff and medical staff in terms of what procedures and who has main authority when someone is in medical danger, when there has to be a cell extraction. In recent years, there have been some very unfortunate incidents in which custody staff concerns seem to outweigh the concerns of the medical staff. And I'm asking the receiver, what has your office done to develop a formal procedure that clarifies what happens in these situations, and what type of training, if any, has been put in place now for custody staff and medical staff? And ask CDCR, too, what kinds of specialized training and written policies are you giving custody staff before they go to work in these medical units?
Well, first let me address the, what have we done to try to formalize an evaluation of these incidents. As these incidents have come up, we, of course, have raised the problems that have been identified with the Secretary and the executive staff within CDCR. Oftentimes, OIG is involved because these tend to be incidents that trigger some type of investigation. So what we do in response is reiterate what the existing policies and procedures, I think, clearly provide in terms of who has what responsibility given a particular type of incident. I think our policies and procedures themselves are fairly clear about this.
There is a formal procedure. So we think we have acted proactively, and really all we can do after an incident occurs is to try to figure out who's responsible.
Well, it's certainly part of it is finding out who's responsible, taking any appropriate disciplinary action. Part of it, though, is using those incidents as an education opportunity within the department. We already do, as I think we'll be able to tell you, there's already training at a field level. What we do after we have one of these incidents is make sure that we highlight this to leadership, both at headquarters and, more importantly, I think, to wardens and to high-level leaders at the institutions. And these are topics that at regular meetings of wardens and institutional execs, these are topics that we talk about. The need to be able to tell when something is a custody issue, when it's a medical issue, the need of sometimes our own medical leadership at institutions. They fail to step up and say, no, we need to be the ones taking the lead here. So it's an ongoing discussion about that coordination. Again, I don't think our policies on this are deficient. I think it's clear that that's all right. I think it's clear when it should be a healthcare decision versus, in general, a custody decision. I think it's training and further discussion.
Yes. So we do have our use of force training that we've rolled out statewide. And so I had an occasion last February to, not this February, 2016, 2015, to attend a training down in Bakersfield. And it was very scenario-based where, you know, you go through the scenarios, and they actually used a lot of medical examples in how to do controlled use of force versus immediate use of force, and to see how we can do those de-escalation techniques so that we don't get to a point of use of force. And so I think that you know, that training has just rolled out, and we're already seeing some reductions in use of force, I believe. But also in just the day-to-day operations, which I think you're concerned about, is what if there's a disagreement between healthcare and custody? You know, they have been instructed on how to work that through their relative chains of command, whether that means that it needs the nurse on the unit wants something done and custody is saying no, then elevate it up through the chain. If it needs to go up to the CEO of healthcare and the warden of the institution, or even up to the regional healthcare executive and the associate director for custody, then that's what needs to be done. So we do have some processes in place to just also help with the day-to-day operations.
Okay, thank you. Has the department given any thought to greater use of medical technical assistance, instead of correctional officers, for interacting with particularly mental health incidents? These are people, as you know, who we use in our state hospitals,
Right.
which are 95% forensic referrals. And since they do have specialized training, if we're not going to give that training to the correctional officers, why would there be a problem in using those MTAs?
So, well, currently, right now, we do use the correctional officers and an assortment of licensed healthcare professionals to deliver care to the patients that we have in the inpatient settings. And, you know, just recently, I was at CMC, and I had an opportunity to talk to them and the custody officers that are on that unit. And so the custodial officers that go on that unit, they bid to be on that unit. They were very proud of the fact that the majority of them had been there for a number of years, and as new custodial officers come onto that unit, they get a specialized 2-day training on the therapeutic environment and how to interact. And, you know, sometimes these units aren't for everybody. You know, you find that out as you go in, and they do have the opportunity to bid out. And also, you know, you do have supervisors there, and maybe they feel that maybe the employee doesn't realize, but maybe this isn't the right, and we can move someone out of the unit. And so right now, that's the model that we are using. For CDCR, the class had been abolished, but we're not in opposition of using the MTA classification.
Okay, and what special training do we use for interactions with inmates with disabilities? And I ask because that has come up a number of times. Most recently, in the OIG's look at High Desert State Prison, where there was a particular incident of a person with hearing disabilities being involved in a use of force incident because there wasn't recognition of the disability. Again, I've also heard that in other prisons that disabled inmates are having a hard time.
So, you know, in the specialized medical units, they are given an Armstrong, you know, which is our disability lawsuit, Armstrong overview. They are given an Armstrong overview while they're in the academy. And also during their annual block training, they are given some training. But as I was speaking with the receiver earlier, there's no substitute for ongoing on-the-job correction and readjustment.
Right. So as long as we have the need for it, does the department have a formalized way to ensure that people get it? So it isn't an after the fact, who's responsible, but a before the fact, particularly in a place like High Desert, which had a lot of disabled inmates because of its physical structure.
Right.
Do you have anything like that?
You know, I would have to get back to you to find out exactly what the training is, because I don't want to misspeak and tell you something.
Okay, Senator Bell?
Well, as you know, we did the mental health training and disability training legislation last year. The first bill was SB 11, which dealt with academies for police officers. The second bill was SB 29. That bill was for field training after they were accepted into service. And when we went through the 2-year process of developing these bills, we found that both are needed, that you have to have an academy initial training. And one of the reasons why is the academy is the place where you sort of find if the candidate for employment is acceptable in terms of dealing with people with disabilities and mental health problems. So you sort of are able to find out if the candidates are acceptable. So you create if you put it in the academy, you create then a standard that you're requiring them to meet before they're accepted as an employee of our organization. So, they have to pass muster, if you want to say it that way. Then the field training is of course, very important in terms of skill set development and dealing with understanding disabilities and other kinds of issues, mental health issues and so forth. So it behooves us not to do both, okay, is what I'm saying. And I think when we develop these skill sets, we also have an academy and have the instructors and the people that review the candidates have some kind of way of qualifying our candidates that they have an acceptable skill set and understanding of issues of disabilities, mental health, and so forth. So I would urge both. Okay, thank you, Madam Chair.
Thank you. And then I have just one last sort of comment question. Has the receiver considered in particular whether there are any of the court orders that should be codified in statute before the final transition?
Yes, we've had a team working with CDCR on that project. My understanding is that we are waiting till we're just a little bit closer to the receivership concluding before bringing forward those proposals.
Okay, but there will be proposals. Good, because I think
a fair amount of work has already been done.
Yes.
excellent, that we probably, both the policy and budget people, would like to work with you to make sure that we can do that. Are any other questions from the subcommittee?
Madam Chair, thank you. And first of all, I want to applaud the work that has been done. It has not been easy, and it was done over a period of time. And I applaud the hard work that everybody put in, especially our receiver Clark Kelso and his staff. and the department in terms of improving the healthcare in our facilities. I think that we've come a long way in the last decade in California in looking at the relationship between, good healthcare and reduced recidivism. And when people are out in the community, they are put out in the community in a healthy way. They're able to function. There's one area that I have a major concern about, that I believe when we started the process of the receiver and the original decision, and I believe it was made by the courts, and you can describe it, that we didn't really fully deal with the issue of addiction and care for inmates that have previously had addiction problems. As you know, when you have somebody that's limited, treated, or untreated in terms of addiction, the other healthcare costs are 2 to 3 times higher to achieve success when you're not treating the specific addictions. The other issue is how do we, like the monitoring and factual data issue. Do we understand what kind of addiction the people that are in our facilities have, what their past histories have been with addiction? And then I think it's very important, once they proceed into parole and beyond, what kind of problems they then have once they're in our community, and what kind of addictions they have at that point. So I think the whole process of looking at addiction as a medical problem, and a medical problem that results in social criminal activity that hurts our community could be improved, okay? And that whole process needs to be looked at. And what I would urge is the receivers doing a good job. We're focused on this. I would urge that we create some kind of working group to develop strategies to supplement what you've done, the good work you've done, and that we create a working group that include people from inside the correctional environment, but also people that are expert on the outside on addiction, so that we can look at how to reduce addiction in our facilities. And I like to point out, Madam Chair, last year we spent a lot of money talking about this, but the way we talked about it is the issue of screening devices, hiring canine units, other kinds of expenditures that we've made in our budget and added costs but we didn't have any discussion of how to reduce the demand and reduce the acuity of substance abuse and addiction. I think also there's a inherent thing that happens in prisons, and that's that addiction leads to control of persons in the prison by gangs, and it leads to control of people once they get out, their families, the whole environment of drugs in terms of creating an environment for gangs to control people's lives and lead them to criminal activity. So I wanted to know, is there a way we can transition between the Department of Corrections and the receiver on the issue of addiction, and what your thoughts are? I think we need to have a full discussion.
I think it's actually